The subcommittee will come to order, and we will be joined shortly by some of my colleagues, but I thought I would start because of the delay, and Dr. Hodis, I want to apologize to you and the other witnesses and everyone here for that delay. We did have 2 votes, and such is life on Capitol Hill. So thank you again for your patience. I do appreciate that. On December 11th, the G-8 convened a dementia summit in London to examine and presumably harmonize the various national action plans on the growing international crisis of Alzheimer's and other forms of dementia. The outcome appears to indicate a coalescing around the U.S. plan to make significant headway on addressing dementia by 2025, which would have significant implications globally, particularly in low and middle income countries, where increasing aging populations and numbers of people with dementia strain limited resources. On January 4th, 2011, President Obama signed into law the National Alzheimer's Project Act, or NAPA, requiring the Secretary of the U.S. Health and Human Services to establish a National Alzheimer's Project. Among other provisions of that law, the administration was mandated to, quote, 1, create and maintain an integrated national plan to overcome Alzheimer's disease, coordinate Alzheimer's disease research and services across all federal agencies, accelerate the development of treatments that would prevent, halt, or reverse the course of Alzheimer's disease, improve early diagnosis and coordination of care and treatment of Alzheimer's disease, improve outcomes for ethnic and racial minority populations that are at higher risk for Alzheimer's disease, and coordinate with international bodies to fight Alzheimer's globally. That congressional mandated plan apparently found favor with the G8, which endorsed that plan as being comprehensive and forward-looking. But even before the summit, the U.S. National Plan on Alzheimer's led nearly a dozen other nations to adopt their own national strategies. According to the testimony at this subcommittee on November 21st at the pre-summit hearing, this comprehensive approach is vital to meeting what is a looming global health crisis. The World Health Organization's and Alzheimer's Disease International 2012 Dementia Report estimates that there were 35.6 million people with dementia, including Alzheimer's disease, worldwide in 2010. This number is projected to nearly double every 20 years, increasing to 65.7 million in 2030 and 115.4 million in 2050. The global cost of this condition totaled $604 million in 2010, according to the Alzheimer's Disease International. To put this figure in context, Alzheimer's costs would equal the gross domestic product of the 18th place country in the world ranked by GDP. While other G8 countries may pledge funding to Alzheimer's to address Alzheimer's and other forms of dementia in the developing world, we are facing an impending global health crisis over Alzheimer's and other forms of dementia. The 2014 federal budget request for U.S.-funded global health programs was $8.3 billion. The focus is on achieving an AIDS-free generation and ending preventable child and maternal deaths through the administration's Global Health Initiative. Under this budget, maternal and child health will receive $680 million, malaria $670 million, TB programs $191 million, and neglected tropical disease programs $85 million. Pandemic influenza and other emerging threats would receive $47 million. WHO estimates that more than half of global dementia cases are in low and middle income countries where cases are projected to explode. Across Asia, Latin America, and Africa, these developing countries are expected to see rapid growth in dementia cases over the next several decades. In 2010, roughly 53% of dementia cases were in low and middle income countries. By 2050, WHO expects 70% of all cases to be found in those countries. So how will this impact our foreign aid portfolio, especially as regards to global health funding? We need to better understand the level of international cooperation our government can expect in the search for early detection techniques, prevention, and treatment of Alzheimer's and other forms of dementia. There has been collaboration among scientists across borders on HIV/AIDS, but how much can we expect on the various forms of dementia? Many countries in the developing world don't even have a surveillance adequate to provide reliable statistics on the incidence of Alzheimer's and other forms of dementia. Given the negative impact of the brain drain, they may not be able to be the active, effective partners we need them to be in this area. However, without their help, it will be difficult to even formulate programs to help such nations cope with this growing health threat. These are questions we hope to have addressed, if not answered, at today's hearing. The administration was unable to participate at the subcommittee's November 21st hearing, but we have the head of the National Institute on Aging to provide the administration's view on what the summit produced. We're also joined by two representatives from the NGO community, both with long and distinguished careers and advocacy efforts that have really made a difference, who also participated in the London summit to give us a private sector view of those proceedings. We will need more than rhetoric to deal with this crisis. As more of us live longer worldwide, the threat of developing Alzheimer's or some other form of dementia grows exponentially. We cannot afford to have a robust domestic program to fight this condition and find that our international efforts are undermined by the failure of other donors to play their proper role in this effort. I'd like to now yield to my good friend and colleague, Ms. Bass, for any opening comments.
Thank you, Chairman Smith, once again for your leadership of this committee and for holding this hearing, which is of importance to all of us. I also want to thank our witnesses this afternoon and applaud them for their ongoing contribution to the U.S. leadership and robust global engagement in this field. I am struck by the number of people worldwide who are currently living with dementia, which I understand ranges from 36 million to some 44 million people, many of whom live in the developing world. The fact that the United States is engaged with other nations in addressing the challenges of dementia is therefore highly encouraging to me as a legislator and speaks to the common goal needed to resolve the medical conundrum that is dementia. I believe it's fair to say that here in the U.S., all of us have been touched by stories of families, I know I certainly have, friends and neighbors caring for elderly relatives diagnosed with dementia. Many of these caregivers could not have done so without the tireless support of professional health workers and caregiver support groups. Such is the devastating impact of dementia. All of us wait in anticipation for a cure. At this time, I want to thank, I know my colleague, Congresswoman Maxine Waters, will be attending soon. I want to thank her for her leadership on this issue as she serves as the co-chair of the Congressional Caucus on Dementia. Representative Waters has kindly agreed to address this hearing today in my stead, and I know both of you, well, you are co-chairs because I believe you founded the Caucus on Dementia.
Marky did, but he asked me to join us.
Oh, wonderful. Well, I know that Representative Waters will be joining us soon, and I will get information from the two of you when it's over. So thank you very much.
Thank you so very much, Ms. Bass. I'd like to now introduce our very distinguished first witness. And without objection, I would ask unanimous consent that the G-8 Dementia Summit Declaration, as well as the Summit Communique, be made a part of the record. Dr. Richard Hodis, if you don't mind, Doctor, we'd like to wait another minute because I knew 3 or 4 other members are on their way, and I would hate them to miss your testimony, if that's okay with you. So we'll stand in a very, very brief recess because I know there's at least 3 members that are on their way. I'd like to yield to the co-chair of the Alzheimer's Caucus, my good friend and colleague from California, Maxine Waters.
I'd like to thank Chairman Chris Smith, the co-chair of the Congressional Task Force on Alzheimer's Disease, as well as ranking member Karen Bass, for organizing this hearing and inviting me here to participate. As the Democratic co-chair of the Task Force on Alzheimer's Disease, I know how devastating Alzheimer's and other forms of dementia can be for individuals and families. As populations age, more individuals are likely to be affected by Alzheimer's and other forms of dementia. According to the World Health Organization, Alzheimer's disease is the most common form of dementia, accounting for 60 to 70% of the dementia cases worldwide. Here in the United States, Alzheimer's disease is the 6th leading cause of death, and it affects over 5 million American families. 1 in 9 Americans age 65 and older has Alzheimer's, and 1 in 3 Americans age 85 and older suffers from this disease. The Alzheimer's Association estimates that more than 7 million Americans over age 65 will have Alzheimer's by the year 2025. Every 68 seconds, another person in the United States develops Alzheimer's. Caregiving for dementia patients is especially difficult. More than 15 million Americans provide unpaid care for a person with Alzheimer's disease or another form of dementia. Caregivers include spouses, children, and grandchildren. Caregivers face a variety of challenges, ranging from assisting patients with feeding, bathing, and dressing, to helping them to take their medications, managing their finances, and making legal decisions. Alzheimer's and other forms of dementia present growing challenges, not just in the United States, but also in many countries around the world. According to data compiled by the Congressional Research Service, more than 35 million people worldwide suffered from dementia in 2010. By the year 2050, that number is expected to more than triple to over 150 million people. The World Health Organization estimates that more than half of global dementia cases are in low and middle income countries. The Congressional Research Service projected that by 2050, about 9 million people in Africa, 16 million people in Latin America, 29 million people in South and Southeast Asia, and 31 million in East Asia will suffer from dementia. Alzheimer's disease and other dementias present special challenges in low and middle income countries. In high income countries like the United States, institutions and programs like Medicare, Medicaid, nursing homes, adult daycare, and other social services provide critical support to dementia patients, their families, and caregivers. However, in most low and middle income countries, public medical and social services for people with dementia are rare. Consequently, care for individuals with dementia in these countries is almost exclusively the responsibility of their families. The G-8 Dementia Summit brought together national leaders from the United States, the United Kingdom, France, Canada, Germany, Italy, Japan, and Russia to discuss a coordinated international response to dementia. I look forward to hearing from the witnesses about their experiences at the summit. I'm especially interested in plans to coordinate efforts to enhance dementia research, treatment, and caregiver support activities. I'm also interested in plans to work with low and middle income countries to prepare them to respond to the needs of growing numbers of families affected by dementia. Once again, I'd like to thank my colleagues, Chairman Smith and Ranking Member Bass, and I yield back the balance of my time.
Thank you so much, Ms. Waters. I'd like to now introduce Dr. Hodis, and I know that others will join us shortly. At least they told us they would. He is the director of the National Institute on Aging at the National Institutes of Health, a leading immunologist. Dr. Hodis was named director of NIA in 1993 to oversee studies of the basic clinical and epidemiological and social aspects of aging. Dr. Hodis has devoted his tenure to the development of strong, diverse, and balanced approach to research, focusing on the genetics and biology of aging, basic and clinical studies aimed at reducing disease and disability, including Alzheimer's disease, and age-related cognitive change and investigation of behavioral and social aspects of aging. And without objection, his full resume will be made a part of the record. Dr. Hodis, the floor is yours.
Challenge in terms of cognitive The lower line, which is very low in 1950, is the proportion of people over 65, and you can see that's down around 5%. There's been a remarkable change in these proportions over time, so that somewhere within this decade, for the first time in human history, there'll be more individuals over 65 than there are children under 5, and those curves will keep on happening. So by 2040 and 2050, we'll have larger and larger proportions of the population at risk for diseases such as Alzheimer's. And notably, we talked about the challenge societally, fewer and fewer individuals at younger ages capable of providing the kind of care that is currently provided informally by family members in large proportion. The next slide is last year's very careful study of the cost of Alzheimer's disease in the United States. In 2010, the first bar illustrates the direct medical care costs, over $100 billion. The next two bars, minimum and maximum estimates of informal care costs, giving a total cost, interestingly, that is in excess of what we currently pay for cardiovascular disease or cancer, and with the trends and projected to continue, as you see here in 2040, as the number of people at risk for Alzheimer's increases. And the next slide. On that background, as noted, a very important event was the passage of the National Alzheimer's Project Act, which mandated a national plan. The goals of the plan are illustrated here. The first one highlighted is the prevention and effective treatment of Alzheimer's disease by 2025, towards which we have focused public and scientific input to the formulation of a number of goals and benchmarks. The other targeted goals refer to optimized care and quality, patient support, enhanced public awareness, and then tracking improvement along these lines. And the next slide is an illustration of the goals that came through in the communique and declaration from the G-8 summit, notably with very strong overlap and consistency with the goals espoused in the U.S. plan. An ambitious goal here of, again, the 2025 target for identifying a cure or disease-modifying intervention or therapy. So a very important event, I think, was the coalescence of international opinion behind this goal and a commitment to do all that's necessary in order to achieve it. The next slide. Importantly, in order to achieve it, is the sharing of information to allow the coordination of efforts. And in the next slide, an example of the very real measures that are now in place to help international collaborations. This particular effort, one which was the outcome of a collaboration between the Alzheimer's Association and the National Institute on Aging, which established an ontology of a way to categorize all of the research that's supported internationally for Alzheimer's related research. It's a database which allows investigators, nations, planners, and funders to understand current cross-sectional and trends in research and to maximize the opportunities, therefore, for filling gaps and for maximizing collaboration. At the G8 summit itself, there was a commitment of the G8 nations to participate even more fully in the establishment of this database and its use in coordinating research activities. Next slide. To illustrate some of the ways in which broad organized programs of international collaboration around Alzheimer's disease are currently in place, I'll show you three examples. This is one that was based on the Health and Retirement Study, a U.S. study that looked at population of retirement age and beyond, looked at variables of health, family structure, economics, and so becomes a population-based study for understanding the risks and, in fact, the incidence over time, trends in cognitive change and Alzheimer's disease, the family and caregiver situations involved in these populations, and importantly, has provided a template then for international efforts across the world, indicated by the map here, so that a large proportion of the world's population on all continents now is engaged in studies through largely NIH support, at least at the level of catalyzing these studies, with coherent and harmonized measures that we can begin to understand worldwide the incidence, the challenge, the societal and economic context in which dementia will occur over years to come. The next slide is an example of another international effort, ADNI. This is the Alzheimer's Disease Neuroimaging Initiative, a really landmark public-private partnership in which the U.S. Public support through the National Institutes of Health, along with private sector and involvement both from pharma, from imaging, from biotech, has set out to understand the early changes that occur in Alzheimer's disease to allow intervention at an early stage, well before symptoms, where there's the best chance to achieve an outcome. The fact that you see reflected here worldwide is that having established this in the United States with the very important leadership of the Alzheimer's Association, again, worldwide ADNI, now has in all the nations, parts of the world illustrated here, parallel efforts. The same studies go on to measure, combine the power of the measurements on many people, to test whether the course and characteristics of Alzheimer's is the same in the United States as well as worldwide, another effort to try to synchronize and harmonize worldwide efforts. And finally, in a third example, the next slide, one area where enormous progress has been made is in genetic discoveries. In the last year alone, there was a doubling of the number of known genetic risk factors, feasible only through international collaborations involving large numbers of people in all of the nations shown here. So yet another example of understanding whether the disease and its genetics are similar worldwide and recruiting experts worldwide into this collaborative effort. The next slide. So there will, in terms of the most concrete mechanism for follow-up from the summit, be a series of legacy meetings. The UK will host one on social impact investment, Japan on new care and prevention models, Canada and France on academia-industry partnerships, although all nations will be participating in these, and announced and accepted at the G8 summit was the U.S. leadership in a meeting which will occur in February 2015 in association with International Summit on Alzheimer's Research, which will convene the broad international community to coordinate efforts that may come forward from that meeting of experts and scientists. And next slide, please. And just a reminder of that summit, February of 2015. This will repeat the summit that was held in 2012 in terms of its format. It will bring national and international experts together to establish priorities for Alzheimer's research, and as noted, we'll have the very particular feature of a session which will involve leadership from international funders and supporters of Alzheimer's research to assure the best coordination of efforts. I thank you for the opportunity to speak and would be happy to address any
Dr.
questions
Hodes,
you might have.
thank you very much for your testimony and for your leadership. Let me ask a few opening questions, and I'll yield to my colleagues for any questions they might have. In reading the action plan, and you talked about it in your testimony, your written testimony as well, it does talk about, and you mentioned it, the 3 venues that will be held, Japan-led, UK-led, and Canada and French-led. Are there dates yet for those?
I am not aware of fixed dates.
You also note, in the action plan, it calls upon WHO and OECD to identify dementia as an increasing threat to global health. Now, as we all know, the Director General of WHO is there, Dr. Chen, and I'm wondering, have they been? Has WHO made this a serious part of their portfolio, or are they on the threshold of doing so? Because they have done some reports in the past, and I've certainly read them, and I know you have as well.
I do not know further of any action taken by WHO since that important statement at the G8 summit.
Okay. So that will be an ongoing case of advocacy on our part to ensure.
Certainly we would play a role as we do in WHO affairs, yes.
Now, in the list of action items, it talks about the UK establishing a new global envoy for dementia innovation. I wasn't sure what that was. I looked, and I'm not sure. How do you define that, or how do they define it?
The intent here, as best I understand it, is that the UK will identify an envoy whose responsibility will be to attempt to correlate public, private, international partnerships towards a common fund of resources in support of Alzheimer's research. And I think that outline is the extent of the notion to date. UK will appoint. The rest of the nations were in full agreement with there being such an individual to take the lead in collaborating international public-private partnerships.
You know, we were all thrilled that the G8 is doing this and the UK did initiate it, but I'm wondering if there's any thoughts to expand it to the G20 and then by extension the rest of the world. Brazil, China, India, Mexico, South Africa, large populations, obviously with large numbers, increasingly large numbers of dementia cases who make up G20 but not G8. Is there an effort to try to bring them into the fold?
Absolutely. As you saw in some of the examples that I cited, there was international representation far beyond the G8. Our plans for the G8 legacy meeting, in fact, will call for invitations far beyond G8, and there are many more nations than that currently involved in Alzheimer's research who are being asked to contribute to this ontology database I mentioned. But without question, G8 was a very important set of leadership nations, but all of our international efforts will extend far beyond that to far broader international partnerships.
You know, one of the bullets in your testimony is increase the number of people involved in clinical trials and studies on dementia. Obviously, domestically, that will include African Americans. It will include all people from every ethnic group in all of the G8 countries. But is there any effort to try to include Africans and those who might not usually be part of these trials? Because we've been noticing, especially where longevity is now becoming a positive statistic, people are living longer, obviously, that we're going to see a huge epidemic of dementia, for want of a better word, in places like Africa, with a decreased ability to cope with it.
The challenge, if I can summarize it quickly, in carrying out the kinds of intervention, clinical trials, which are currently happening, is that the greatest emphasis is on analyzing people who are at high risk for disease long before there is symptoms of disease and tracking biomarkers such as through brain and neuroimaging, genetic analysis, and so on. It is currently challenging to do these kinds of studies, tracking such markers in nations that do not have the infrastructure for that kind of imaging. The way in which we are trying to do, though, is illustrated in one study to attempt to maximize this. This is a study looking at individuals with early onset genetically determined Alzheimer's disease due to a specific mutation. They have brain change detectable decades before they have disease. There is the largest familial cohort of these in the South American country of Colombia, which is relatively less developed in terms of its biomedical research infrastructure. So in this case, NIH, together with partners, are supporting studies in which those individuals will be studied both through establishing capacity in Colombia and through travel to the U.S. as one of the examples I can cite in which a generally less well-developed country can be supported for research as demanding as it is in cases where this is particularly important to the research effort.
You testified that the International Genomic Alzheimer's Project has discovered 11 new genes connected with the condition. How will these discoveries advance identification, prevention, and treatment of Alzheimer's? And with the collaboration that now has gone into a much greater area, of cooperation, have we already seen some things that we were not aware of coming out of some of the other, the other countries that are part of this initiative? Are we saying, hey, we didn't know that, give us the information on that?
Well, in fact, the information that led to the description of these 11 new genes came only when we were able to look at enough subjects with and without disease that could be provided by international investigators. No single country, no single population of available data had the power to identify these new genes. You asked the very important question about what happens next once we identify genes as risk factors. An important observation of the genes described so far is that they tend to fall into families or pathways, many of them related, for example, to inflammation, others to transport of membranes. When we have these clues, this drives the next generation of research, which looks at ability to intervene and change the variables that are determined by these genetic risk factors, and to look for clues that these are targets then for eventual clinical intervention. This is a difficult and challenging road, but each one of these new genes and gene pathways we identify provides a new potential target for next efforts at intervention.
Let me just ask you one final question with regards to money. Are we appropriating sufficient amounts of money for research for Alzheimer's, and are the other countries doing likewise? It seems to me that one of the greatest models we have is PEPFAR in terms of the United States led, and other countries did indeed follow, and now the whole world is on the same page trying to mitigate the scourge of HIV/AIDS. And I'm wondering if this G-8 summit was the catalyst, and whether or not we do indeed have a Manhattan-type mindset to really eradicate or at least find a therapy for dementia by 2025.
Well, I think it's certainly clear that the scientific opportunities that we have before us in areas of Alzheimer's research are vast, and that the current fiscal constraints that we have are without question providing an important determinant in what research we can carry forward. We're gratified by the additional funding in 2012 and 2013, which added to our ability to carry out important studies. We're hopeful that there will similarly be increased in funding available. The scientific opportunities, I think it's fair to say, in direct answer to your question, far exceed our current ability to fund all of the meritorious ideas, and we remain committed, understanding the reality of fiscal limitations, to doing the very best we can with resources available.
I know it's perhaps a difficult question for you to answer, but could you give us any kind of sense of how many laudable projects fall off the table because they cannot be funded because there's insufficient funding?
I can give you just an overview in the sense that currently at NIA for Alzheimer's research, as for all of NIH, the success rate for applications is in the range of 15%. I think there is, of all applications received, I think there's wide agreement that meritorious, outstanding applications are fairly uniform through nearly double that amount. So one could safely say if we did no more than fund all the meritorious applications that we had before us, even without taking measures to more actively solicit additional applications, that we could fund twice as much research as we are currently able with the resources in hand.
Do you have hope that the G8 summit will produce a catalyzing effect of, I mean, we saw it with HIV/AIDS. Once the bidding war, in a positive sense, started, countries began to step up to the plate. The Global Fund swung into action, and in every aspect, it was like, we're going to resolve this. We're going to stop this pandemic, as Henry Hyde called it, the prime sponsor of the PEPFAR program. He called it the Black Death of modern times. And it wasn't until that started that we moved into a situation where real resources were being brought to bear. Do you think the G8 summit may have had that?
I think
have that consequence?
what I can say comfortably is that we have an enormous responsibility to show in the abstract and also in specifics that there are scientific opportunities before us that are likely to provide the kind of progress necessary to achieve this goal of intervention and cure by 2025. I think that the G8 summit was a landmark in that it brought together scientists who could make the very specific case with specific plans underlying those aspirations, and that this was embraced, as you saw, by the common goal across nations. Having met, I think, the important obligation to show that there is a real plan in hand with a rational approach to conducting research that will take us to the goal in mind, I think we now stand and are hopeful that policymakers will take maximal advantage of the information we can provide, ask us to provide more than we can, and leave to your hands what we hope will be a translation of these opportunities into research and real progress towards that goal and timeline.
Thank you, Dr. Hodis. Mr. Weber.
Gosh, I don't know where to start. Dr. Hodis, you said in Columbia y'all had identified, was it the largest biofamilial group?
Yes.
Okay.
Discoveries in the 1990s uncovered some very rare but tragic and informative populations in which a mutation in a single gene, actually one of 3 different genes, caused Alzheimer's disease in anyone who inherited that disease. Mendelian inheritance, so-called. 50% of the offspring of somebody with that gene would have the gene. If you had the gene, 100% certainty of getting the disease, age of 50s, 40s, even 30s. One such large family exists in Colombia. It's known exactly what the mutation is in those individuals. It's known that if you look at people with no sign of disease at all and do brain scans in their 30s, that individuals who have not inherited the gene all would have a normal, if you will, brain scan, in particular without evidence of deposit of amyloid plaques. But the individuals who are in their 30s, who are not destined to have Alzheimer's disease for another 15 or 20 years, but who have the gene, already show clear abnormalities in their brain scans. This means there's an opportunity to try to intervene with treatments before potentially irreparable damage has been done to the brain, long before symptoms, by using experimental treatments and tracking the biomarkers like brain scans to see if these treatments are effective. Because this is such a large population, it is an enormous scientific opportunity. It's also a population, as you can imagine, just desperate to be a part of a search for a goal. So in collaboration with investigators in the United States and in Colombia, with support from private sector as well as NIH, these individuals will be studied for interventions beginning years to a couple of decades before they actually develop disease, to see if we can make progress in arresting the underlying pathology of Alzheimer's disease.
Okay, you said a large group. Is that, and you may not know the exact numbers, I mean, is it 5,000, 20,000, 150,000?
The number of people in these families is in the range of 3,000. Approximately 500 will be studied.
Okay. And then you said, the chairman said, and I came in late, so forgive me, I didn't hear all of your testimony, but you discovered 11 new genes.
Yes. New genes that are risk factors for Alzheimer's disease. And important to distinguish the kinds of genes we just talked about, 3 genes which guarantee that one will, unfortunately, tragically, have Alzheimer's disease if you inherit that gene. These are real Alzheimer's causal genes. All the rest of the genes we talk about are risk factors. That means if you have the bad variant, the bad allele of that gene, your probability of having Alzheimer's disease is increased. It's not 100%, but it's a signal that something about that gene is involved in the process of Alzheimer's disease.
So these are not new genes. We've just discovered the link to Alzheimer's.
Fair enough to say. That's right.
Right.
Since the solving of the human genome, all the genes are there. You're exactly right.
And
What's been done is to show that these are linked to Alzheimer's disease.
How many is that? Ninth grade physical science for me was way too far back. How many genes is there?
In the range of 25,000.
25,000. Okay. So how do you intervene and change an individual who has inherited these genes? Does it take diet? I mean, how does that work?
Well, just as an example of the kind of logic that is followed, if one finds that a number of these genes seem to be in pathways for inflammation, and if there is evidence, as there is, that inflammation may play a role in the brain of those with Alzheimer's disease, one takes this and uses it to design interventions that may, for example, decrease or modify inflammation in the brain to see if this will have a positive effect on the course of disease. So it isn't necessarily a sign that that person with that variant is the only one for whom that intervention makes sense. It's saying that the pathway involved in Alzheimer's is identified by these variants or mutations, and it's those pathways which then become the target for experimental interventions.
Are all the other countries involved in this? Are they, and I hate to use the word co-equal partners based on population, but how do we measure their seriousness? I'd like the chairman to ask, there's not enough money. How do we get them to the table?
Well, in some specific cases, such as the example of genetics, there are clear and strong international collaborations already. In terms of having the full scope of international collaboration in Alzheimer's research, one of the initiatives that we mentioned, an international Alzheimer's research database that was generated by the NIA in collaboration with the Alzheimer's Association, is in the process of compiling all of the research supported nationally, internationally, by government and private and philanthropic agencies. This, for the first time, provides an opportunity to go online and ask any of the questions that you would like to for a given nation, a given organization, in a given area of research. With change over time, what is the level of support? To many purposes. One is to address perhaps the question you've asked about the distribution of support internationally, but even at the level of the individual scientist or funder, one can go on to see if there are gaps, if there are important areas of research that are being underdeveloped, and to look at this across nations and even coordinate the efforts of nations to invest with the same database, the same understanding of where we stand now and what the needs are.
In part of your comments, you said we're interested in learning from other countries' successes, and so I guess my question is, are we?
I think there are categories of research carried out in an individual laboratory which then become internationally shared and inform all of us. So in that respect, some of the discoveries of genes or underlying processes, whichever country they arise, are communicated internationally and inform all of us. And this is one of the important commitments, and it came out of G-8 as well, to enforce or inform a culture of data sharing so that when information is made available, it's made available as quickly as possible to all nations. In the area of the underlying basic biology of Alzheimer's disease, we look at diverse populations, see if there are differences in risk factors across countries. These do inform all of us. I think in that respect, we are learning by international comparisons. For example, there are two that I can cite. There was one study that was called the Indianapolis-Ibadan study. African Americans of Nigerian descent from around the area of Ibadan compared to residents in Ibadan for genetic and clinical manifestations of Alzheimer's disease have revealed different influences of genes and environment. Similar study looking at Japanese immigrants to Hawaii and comparing with their Japanese populations who remain in Hawaii. So these are some examples by which we can learn the effects of environment and their influence on genetic predispositions or protective factors as well. I think these areas of research, and these are only examples, do provide the positive answer that yes, we learn from the experiences of internationally. In terms of the health and retirement survey, which I mentioned, we're just beginning now to have the capacity to look in countries internationally at their health status, their incidence of new cases of Alzheimer's disease, their relationship to family structure, how care is being provided. This is the first step in learning from one another, learning lessons to even have that information. But in recent years, as that particular map that I illustrated showed, we're making enormous progress in having studies that are interpretable in a similar and common way across countries, both developed and developing internationally.
And how is that information shared? Is it done through summits, through publications quarterly, through emails instantly? How's that information shared?
Yeah, all of the above, and perhaps some of the more organized examples that we provide are in the databases that I mentioned. Easy to see in genetics, for example. So in 2012, as part of the presidential initiative in enhanced support for Alzheimer's disease, there was money committed to sequencing the genomes of people with Alzheimer's disease and control people who did not have Alzheimer's. The sequencing, the DNA is collected, the sequencing is done. As soon as it's done and quality control is completed, they are posted in an international database. The first group announced in December, the next in a month or two. So they are these data instantly available and announced as such to the scientific communities. This is a prototype of the way we attempt to not only have the data available as quickly as possible, but in a place where people know to look for it and where the ability to manipulate those data is maximized.
And is there a parallel track for independent companies, drug research companies? Are they at the same time racing to discover this at the same time?
So there are areas of research in which there's a great deal of competition. Certainly the drug companies are doing some things independent of, for example, federal NIH efforts, but some of the large prevention trials which are being funded the last year or two with current and enhanced U.S. funds from and through NIH have important collaborations and co-funding by industry. This is most obvious in the cases, of course, where there's an intervention of something that is proprietary. But the Alzheimer's Disease Neuroimaging Initiative, a very large initiative designed to identify the earliest changes in Alzheimer's disease, brain images, biomarkers, is being supported by extensive contribution from industry, NIH, all of that with no selective advantage to anyone. The data become immediately available and posted to all. It's perceived by all involved to be of such advantage to both private sector and public that this common good and goal has, to the credit of all, I think, led to essentially instant access to these data.
Okay. I think I've exhausted my pea brain. Okay.
Dr. Hodes, just a couple of final questions. The point of developing an international action plan for research, what does that look like, and who would take the lead? Is that a WHO lead, or is that a U.S. lead? Will there be people actually tasked for research, or will it be just a broad brush, set of bullets on a piece of paper? And secondly, are existing U.S. resources sufficient to implement these goals, since there will be a great deal of sharing and collaborating? And do we, you answered the question about research dollars, but what about to implement this new global summit agenda?
So just to outline the way in which the research agenda in the United States has been developed or presented, we recognized with the national plan an enhanced need to bring to bear the best of international expertise in deciding priorities and strategies in order to pursue these research areas. This was done in a summit in May of 2012, and there's some 500 participants. The outcome was a series of recommendations by this international group of experts as to where priorities lay. Those priorities and goals were translated into milestones, what it would take to achieve them, what kind of research on what schedule. This has all been shared with the national and international research community, and we are in the midst of tracking progress towards them, funding and supporting that research as best as we are able. Currently, international funders have access to the same information through the efforts of NIA in collaboration with the Alzheimer's Association. We are convening annual meetings and, more frequent than that, teleconferences of international funders of Alzheimer's research, trying to invite and encourage common planning around these milestones. So I think a well-developed, evidence-based plan with targets, goals, milestones developed through the U.S. to the degree to which this can be implemented at an international level, I think we will see in some of these meetings to come are able to muster international support behind them. So the process, I think, is there. The international collaboration remains, I think, to be optimized, but I think the will has been expressed at G-8 and subsequently in a very positive sense. And the way in which the resources of all of these countries might contribute to this common plan, achieving these common milestones, is exactly the kind of planning that one would like to see. It has not yet occurred. Again, I think the G8 is a step towards expressing international will, not just by the G8 nations, but they as emblematic of a broader international community to converge on common goals.
Thank you. Dr. Hodis, I have some additional questions, but I will submit them for the record, and I know other members will as well. So thank you so much for your leadership and for your testimony today. I'd like to now ask Mr. George Rayburn, who is the chairman and co-founder of USA Against Alzheimer's, an education advocacy campaign committed to mobilizing America to stop Alzheimer's and convener of the Global CEO Initiative on Alzheimer's. He also directs Leaders Engaged on Alzheimer's Disease, a coalition of Alzheimer's serving organizations. Through the Rayburn Foundation, he has supported the Alzheimer's Disease International World Alzheimer's Reports and the NIH Global Alzheimer's Research Summit. He has been named by the Secretary of Health and Human Services to serve on the National Alzheimer's Advisory Council to advise on the first-of-a-kind National Strategic Plan. And prior to December 2003, he held several senior executive positions in large media companies. We'll then hear from Mr. Harry Johns, who became President and Chief Executive Officer of the Alzheimer's Association in 2005. He has worked to build momentum for the cause by working to increase awareness and understanding of Alzheimer's, emphasizing progress through clinical studies, focusing on public policy and advocacy, and targeting high-impact research in detection, treatment, and prevention of Alzheimer's. The Alzheimer's Association International Conference is the world's largest meeting on Alzheimer's research. In 2011, he was appointed by the Secretary of Health and Human Services to the Advisory Council, and before joining Alzheimer's, Mr. Johns spent more than 20 years with the American Cancer Society.
Thank you, Chairman Smith and Congressman Weber, and thank you for convening again this very important follow-up meeting to the one that you held 2 months ago, just prior to the G8 summit. You asked at the outset, Mr. Chairman, what the private sector view is towards the G8 summit, and I would say that it's a potentially transformative event, potentially transformative. It set a global goal of stopping this disease by 2025. It set in place some key landmarks in terms of an international research plan, innovation, and it also committed to collectively and significantly raising the level of public resource devoted to research. Now, those commitments are yet to be fulfilled, and of course, one of our roles, or at least I see my role, is trying to press to make sure that those roles are fulfilled. We will have, during 2014 and early 2015, a series of legacy workshops that will follow on, and each of those should be designed to set some very clear action plans in place that can be done at an international level so that we move this pile forward, not just for the 5 million Americans in the United States, but for now the 44 million people around the world. Prime Minister Cameron gave a very eloquent, very passionate speech in which he analogized the G8 summit to the one held in Glen Eagles by the UK several years ago, and which stimulated and accelerated the efforts against HIV/AIDS. So he positioned this summit precisely as you have positioned this, and that is to begin to get the globe to attack this problem as a global problem affecting millions, tens of millions of people around the country. 15 years ago, it was U.S. leadership that helped mobilize the global community to combat HIV/AIDS. The G8's embrace of a goal to develop a cure disease-modifying therapy by 2025, which is the United States goal, signals that U.S. leadership is once again becoming critical to another global effort, this time to stop Alzheimer's. Now, just a word on vocabulary here. The United States, we tend to call this Alzheimer's and other dementias, referring to the entire field. The rest of the world tends to call this dementia, of which Alzheimer's is a major portion. So by use of Alzheimer's or dementia, I encompass the same scope. As we discussed in November, the parallels between the scale and scope of this disease and global HIV/AIDS are striking. Shortly after our November hearing, and just before the G8 summit, the Alzheimer's Disease International updated their prevalence figures based upon new studies in China, Sub-Saharan Africa, and new population estimates from the UN. Those estimates indicate that they now believe that 44 million people have this disease, a 22% delta over what they estimated before. And if current trends remain as they are, They estimate 75 million cases by 2030 and 135 million cases by mid-century. To put those in context, 44 million people with dementia is larger than the population of Canada, Poland, or Argentina. And 135 million projected by 2050 is a number that exceeds the population of Japan and nearly that of Russia, the 10th and 11th most populous countries. Those numbers somewhat understate the impact of the disease since they do not account for family caregivers, and family and other caregivers, which based upon U.S. experience means that the total number of persons impacted with this disease may be 3 or 4 times the numbers that are actually attributed to those with Alzheimer's themselves. And as you've mentioned before, perhaps equally concerning is the fact that 62% of these cases currently are in low and middle income countries, with an estimate that it will move to 70% by 2050. Think about the scale of the disease and its caregiving burden will have on economic development gains made in global efforts against poverty, and on our efforts in women's empowerment, since most of the caregiving burden is borne by women. So this is an economic development issue, not just a health issue itself. The HIV/AIDS epidemic spurred leaders in the U.S. and the world to respond with a global fund to treat AIDS, tuberculosis, and malaria, as well as PEPFAR, as you've already mentioned. Often overlooked, however, is Congress's leadership in driving both of those programs. In the summer of 2000, Congress passed and President Clinton signed, don't want to be too familiar, into law the Global AIDS and Tuberculosis Relief Act. That law authorized an aggressive U.S. response to HIV/AIDS, established the World Bank AIDS Trust Fund, among other things, which subsequently led to the succession of funds that we have today. So it was Congress's leadership in driving this that, in fact, caused those funds to come into existence. What have we learned from the HIV/AIDS experience? Peter Piot, the former head of UN-AIDS, the person responsible for driving the global effort against that disease, turning it from an epidemic to a manageable disease, calls Alzheimer's the next great epidemic and a public health time bomb. With Alzheimer's, we're on the verge of a humanitarian crisis that is potentially larger than the threat posed by HIV/AIDS. Beyond the public health challenge, we're also on the front edge of an economic and fiscal crisis. The cost of Alzheimer's to healthcare and social support systems is huge and growing, already at more than 1% of global GDP. And Alzheimer's is a significant driver of the growth in entitlement spending in developed nations as well, resulting from the rapid aging demographic. In its 2010 report entitled Global Aging, An Irreversible Truth, Standard & Poor's, who does rate sovereign debt quality, identified global aging as the dominant threat to global economic stability. Without sweeping changes to age-related public spending, they opine sovereign debt will soon become unsustainable. When you overlay the specter of nearly 140 million persons with dementia by mid-century, together with their caregivers, the need for a coordinated and robust action for a range of health, economic, and physical reasons at the global level is apparent. Now, the G8 Dementia Summit set out the basis for a global plan and global funding mechanisms to respond to this challenge. The G8 nations, including the U.S., committed to identify a cure or disease-modifying therapy for the disease by 2025, to increase collectively and significantly, their words, the amount of public funding for dementia research to reach that goal, to develop a coordinated international research action plan, to encourage innovation in discovery and care, to develop national incentive structures to encourage those innovations, to report on those commitments to ensure progress is made. The UK committed to appoint a global dementia envoy, which, as Dr. Hodis mentioned, is patterned on the fact that there were global dementia envoys around HIV/AIDS, to stimulate innovation and to coordinate international efforts to attract new sources of finance, including a possible public, private, and philanthropic fund to support global international action on dementia. The G8 ministers did commit a series of legacy workshops in 2014 and 2015 to assure that action plans are developed, executed, and have the intended effect, and I think it's on the part of the NGOs one of our responsibilities to assure that those occur, the action plans are developed, and that we report them back to you, subject to your calling us again after those legacy workshops are held. I would urge this Congress to embrace the commitments by the G8 health ministers, lay the foundation for an aggressive engagement by this country in a global action plan and corresponding global funding mechanism, just as you did nearly 15 years ago for HIV/AIDS. Just as our national plan to address Alzheimer's focuses on research, care, services, and support for caregivers, so too can a global strategic plan. A global action plan should also set international norms for research, care, long-term supports and services so nations can learn from each other about what is expected, what is possible, and what mechanisms can be adapted from higher performing nations for implementation in lower performing nations. One example of what a global action plan might embrace is a reform of the clinical trial infrastructure. At the G8 summit and related follow-on events, a clear consensus emerged from industry, academia, and government that reforms in the clinical trial process would be a major step forward to reducing the time, cost, and risk associated with developing disease-modifying Alzheimer's therapies. It takes far too long, costs way too much money to recruit and enroll patients in trials, to assemble the needed infrastructure anew with every drug candidate, and to conduct the trials only to see the handcrafted trial infrastructure and learning for that trial dismantled and lost so it's not available to other drug companies and other drug candidates. Recognizing this, the Global CEO Initiative, which I convene, working with the New York Academy of Sciences, has made addressing this gap to develop a global Alzheimer's clinical trial platform a top priority for 2014. Such a platform would be the type of groundbreaking initiative that could be supported with a global strategy and fund. A global funding mechanism to drive this innovation, to broaden the targets of attack on this disease, and to scale improvements in quality care delivery is essential to drive this action plan. Low and middle income nations do not have the biomedical infrastructure needed to advance research, but are necessarily experiencing the same humanitarian and economic costs of this disease. So they should contribute to a global fund, even if they may not be able to conduct the research themselves in their own countries. One thoughtful idea put forward by Drs. Ron Peterson and Nick Fox, which I would recommend as well, is to ask each nation to contribute 1% of the cost of care that society is sustaining for Alzheimer's to research. Based upon current numbers, that would imply a global commitment to research of about $6 billion a year. Now, that sounds like a big number, but that's less than what we invest in the U.S. alone for cancer research. It is equal to the amount committed by the U.S. alone to global funds for HIV, AIDS, and infectious diseases. So we're talking about a global fund equal to what the United States itself is investing in cancer or investing in other global funds. At the present time, notwithstanding significant investments to research in other diseases, no individual nation or small group of nation appears to be willing alone to bear even the minimum level of investment needed to attack this disease, either because of fiscal constraints or internal political barriers to strategically reprioritizing research investments towards Alzheimer's innovations. Beyond traditional public investment, the Global CEO Initiative on Alzheimer's, again working with the New York Academy of Sciences, is exploring innovative funding mechanisms that will attract increasing levels of private, philanthropic, social, and financial capital to the Alzheimer's efforts. New forms of crowdsourcing, hybrid philanthropic and financial venture funds, and social impact investing models are emerging in other fields. Efforts are underway to assess their applicability to Alzheimer's. In that regard, we will be working with the UK and its Dementia Envoy, among others. While these clinical trial and financing mechanisms are still in early development, they signal the willingness, indeed the eagerness of the private sector to work arm in arm with governments to address this global Alzheimer's epidemic. And they signal the potential power of a comprehensive global action plan and fund that unifies the diverse stakeholders invested in finding a solution to this disease. Domestically, we must continue to lead the world and deliver on our own commitments at the G8 Dementia Summit by aggressively implementing our own national plan and increasing the level of public resource to support Alzheimer's research and other programs. While government budgets remain constrained, our taxpayers are already paying dearly for Alzheimer's to the tune of $140 billion annually in Medicare and Medicaid costs attributable to this disease. At the same time, we spend only $500 million annually on Alzheimer's research. With that in mind, I'd urge Congress to enforce the commitments in our national plan and take two actions with regard to research. Build upon the increase in Alzheimer's research included in the omnibus bill to double current levels of funding in fiscal year 15. That's domestic investments. And set a marker consistent with the international norm I noted above of committing just 1% of the total estimated domestic costs of this disease to biomedical research. With total public and private costs in the U.S. estimated to be about $200 billion annually, this approach would yield a U.S. national goal of $2 billion in annual research funding, a target that matches the level of funding estimated by leading Alzheimer's experts and recommended by the Advisory Council on Research, Care, and Services as the level of public funding necessary to meet our 2025 goal. Finally, I think it is worth revisiting a recommendation I and other members of the Advisory Council have long supported, a White House level official tasked with coordinating our domestic and international efforts against Alzheimer's and dementia. While I'm not a fan of layers of democracy, I believe strongly in accountability. Congress should consider creating such a position to coordinate both domestic interagency efforts, because they are not just HHS, they're DOD and they're VA, and so they are major interagency efforts domestically, and coordinate our global leadership role, much as we did with respect to HIV/AIDS. Chairman Smith, Member Weber, I thank you again for convening this hearing. I urge this committee to continue its oversight, focus on this issue, and to strongly consider reaching out to additional parliamentarians, particularly those in other G8 member nations, who share your strong interest in and commitment to forming a global working group of parliamentarians against Alzheimer's. Such an alliance would support and indeed, I think, drive the work of government administrations in implementing the G8 commitments and expanding this effort. Thank you very much for reconvening and having me testify today.
Thank you so very much for that very comprehensive testimony and recommendations. We will follow up on it, and I thank you for it. Your testimony is chock full of action items for us, and I thank you for that. Mr. Johns.
Chairman Smith, Representative Weber. First of all, let me thank you for holding this hearing, and Chairman Smith, I want to thank you for your leadership over time on these issues. The NAPA, National Alzheimer's Project Act, has made a huge difference already in the progress we're making on Alzheimer's, and your leadership on that has been really important, as well as the entire Congress. You know, it's an honor to be here. It was an honor to be on the G8 panels to speak to those ministers, as were Francis and Richard Hodis. I just want to talk about three things very quickly in the limited time we have this afternoon. The G8 and the potential to advance the cause as a result of it. What the Alzheimer's Association is doing as a nonprofit in that regard, as the leader in the nonprofit world globally on this issue, and what the United States can do to advance this cause coming off of the G8 summit. You know, we've talked a lot about the data, the statistics. The numbers are staggering, of course, on this. We know already that in the U.S., as you heard from Richard Hodis, that in fact we're going to get to the point of, it's already the most costly condition in the U.S. We're going to get to the point where it's going to cost $1.2 trillion annually just for the care for this disease. So if you project that at all worldwide, you see the kinds of outcomes that it's going to have. Right now, the U.S., North America, and Western Europe takes up 70% of those costs, and fully a third here in the U.S. But that is, as you've already heard, going to grow dramatically across the world and in lesser developed countries. You know, in terms of your question about what's the impact of the G8, I think the G8 does have the potential to be a milestone as an event in the progress against this cause, against this disease. It is ultimately up to what we all do with what occurred at the G8 to determine whether or not it will be something that was small as a milestone or much larger. The kinds of things that were on the G8 communique at the end of the meeting, the 2025 goal, it's a little less ambitious than the 2025 goal contained in the U.S. plan, but important nonetheless to get at what would be either cure or treatment by that 2025 date. Again, not quite as ambitious, but important, and important for us to pursue on a global basis. The increase in research funding that's called for there is absolutely critical to all of this. If we do not continue to increase our funding of research, we simply will not get there as Dr. Hodis indicated. The clinical study participation increases that are called for in the G8 communique are also absolutely essential. The two things that hold back research progress fundamentally are adequate funding and adequate participation in clinical trials. Sharing data, which you've heard about previously already this afternoon, is essential to this. With limited resources worldwide being spent already on this issue, to duplicate efforts unnecessarily, not in the name of advancing the science, but to duplicate those efforts where we will not see the additional gains is simply not useful to us around the world. As you heard Dr. Hodis indicate, the Alzheimer's Association is convening groups worldwide, along with the National Institute on Aging, to look at the very specific funding being done by agencies like ours, organizations like ours, by federal agencies across the world, so that we can coordinate and maximize the returns on investment that we're all making in these things. Through our global research program at the Alzheimer's Association, we fund into 28 countries already today, and we intend to continue that kind of an effort on a private basis so that we can extend the advances worldwide from the best thinking worldwide. You may have heard the story of the young guy in Mongolia who took one of those open access classes from MIT and aced at 100% level with limited other knowledge. Now, that's not an illustration of what necessarily will occur in Alzheimer's research, but by making available more of the information across the world, we can tap what are the knowledge bases of those countries as well, because research historically has not been shared well. So we are working on even another step in this process, which will take the database that you heard Dr. Hodis talk about, a database of research projects, to another level, which would be the sharing of all of the data in those projects, from those projects worldwide. So we need the cooperation of other governments, we need the cooperation of other funders, we need our own federal government to see to it that all of those data are shared. We know that from the convening of our own research roundtable with all of the companies engaged in drug development and imaging and other kinds of aspects of care in Alzheimer's, along with the FDA and the European Medicines Agency, that by putting all of those people in the same room, we can see new outcomes that we otherwise would not see. There's recently an FDA guidance that has made possible new clinical studies that previously would not have been a possibility under the old FDA approach, caused directly by putting all of those people in the same room together to discuss what can be changed. And we will see advances from that, we believe, in the reasonably near term. You asked questions, too, about what's going to happen after the summit. We're working with the Alzheimer's Disease International folks, which we're the sole member in the United States, to convene work groups across the world, particularly in our case on research. We'll lead a research work group that will transcend the G8 and go beyond those countries to try to identify, again, how we can best utilize funding that's available in the world, but also what needs to be done in those countries where the leadership is not present the way it is in the United States today. The worldwide ADNI project, the Alzheimer's Disease Neuroimaging Initiative that you heard Dr. Hodis talk about, is one of the best examples of what can be accomplished in a research effort by sharing those data. There are already more scientific papers, more scientific output from people who were not funded in that study than by the people who originally were. So we've more than doubled the return on the investment from that research. And we can do this across all of medical research, and particularly all of it in Alzheimer's. Now, what can the United States do on this? The very basic leadership of the United States is fundamental to the changes that will occur in this cause, in this particular disease. You've talked about it, Chairman Smith, in terms of what happened in HIV/AIDS, in terms of what's happened in cancer, where I worked for many years. In many ways, I think the model of what's occurred in cancer has shown us the advantages of research investment, whereas the model of the AIDS cooperation worldwide has shown us how to share those data and information. The fact is, if we did not have the National Alzheimer's Project Act, we would not have the G-8. In terms of the question about whether or not the G-8 will become the milestone that we would hope it would be, we have to continue to show the leadership in the United States to advance this cause, to make the commitments to new research funding. Because if we do not show that leadership, I'm confident at least that we will not see the kinds of advances that we otherwise are going to need to have on a timely enough basis to deal with what is the aging of the population, very specifically the boomer generation in the United States. The timeline, as you already heard, for the development of drugs is sufficiently long that if we don't make those commitments now, we're about to hopefully see one that will advance this, but even others beyond that, it's potentially too late to get the job done for the generations that will drive the huge levels of cost that you've heard about from all of us. And seeing to it, again, that those data are shared worldwide will be one of the other things I think that this government can do to make a very big difference in these advancements. Just fundamentally, if we make those commitments today, given the advancements that we hear from the scientific community, based upon what we've already developed, you may not know that the research into Alzheimer's in particular is only about 30 years old. Cancer has been studied for about 100 years. The science community didn't make the connection between what was the woman that Alzheimer discovered the disease in, who was 51 years old, so the disease was considered an anomalous condition of people in middle age. So for 65 years, there wasn't any research done on this. We have a gap then in the development of the research, but we have learned a lot in those 30 years. We are at the point of potentially a tipping point of learning enough to advance those kinds of gains very rapidly. There's a new collaboration that's taking place with the United States federal government, the Alzheimer's Association, and with industry. It's called the Accelerating Medicines Partnership, and the idea of this is to have all those sectors working together with academia to identify the very best drug targets, instead of working alone and in silos, to identify those together so that we can speed the development of drugs on the timeline that I'm talking about. So if in fact we do that, I believe, based upon what I hear from the science community, that we have the very real possibility of making rapid gains on Alzheimer's and other dementias. So I thank you again for holding this hearing and for your leadership on this effort, and look forward to continuing to work to advance this cause and to find the change in the course of this disease.
Thank you, Mr. Johns. Thank you so very much for your leadership and for, again, your very specific recommendations, as well as an elaboration of what you are doing. It was very, very helpful. We're joined by Congressman Chaka Fattah. Chaka?
Thank you, Mr. Chairman, and the chairman and I have worked together on a number of health-related issues, including blood safety and cord blood. It's done a lot of good, and I appreciate the invitation to join you. This is a subject that I have an extraordinary amount of interest in, and I was on the floor, slightly delayed. We just passed the appropriations bill, or we're getting ready to pass it, and included in that is language that I have authored to internationalize the collaboration that we built in at the Office of Science and Technology, Phil Rubin's work. We've created language that would build on the G8 summit and build on the work of the EU and Israel and so many other countries and groupings of countries who have started to focus in on this. And you know, George, you've been way out in front of this for a very long time, but I think I wanted to focus in on what you think the Congress can do. You know, we have the national plan. We put additional dollars. There is, as You've just mentioned, Mr. John, the sense of a tipping point. There's some very important clinical trials that are taking place now, are getting ready to be launched into second and third phases. I mean, there's some things going on, but we are not in any way yet where we need to be. And so I note in your testimony, George, that you suggest that the Congress should, in a similar fashion as we did with HIV, build a much more global approach to this effort. So, and if there are any other specific recommendations that the chairman and I and others who are interested in these matters may be able to focus in on.
Well, you said I was way ahead, but I am following you, Mr. Fattah. You have been in front of this issue on neuroscience and how to get a White House office focused on it across agencies and now internationally, and I commend you on your leadership on these issues. I think that we need to press forward and periodically have this committee and other committees of Congress make sure that we are moving forward during 2014. It is a critical time, as Harry has mentioned, and I agree, that we assure ourselves that we pick this moment in time and say this is a turning point, not just a dot on a long line, so that we in fact hold accountable for all of the commitments that are made out there and insist that the U.S. government demonstrate how it is that they are moving this forward and using their leadership to do so. I've suggested to the chair of this subcommittee that there be a set of parliamentarians that you meet with EU parliamentarians, UK parliamentarians, Canadian parliamentarians, and Japanese parliamentarians to assure that there is political backbone to the commitments that are made, because it's going to take the parliaments of these countries as well as the national leaders and the health ministers to assure that we get to a unified effort. I think that you need to invite the private sector to the table in a genuinely open and joint kind of approach, a unified approach. HIV/AIDS, in the end, I'm not going to say the end, we haven't finished the end, but with respect to what started to drive that was the unity of purpose, the unity of effort, and thus the clarity of a combined plan which everyone's roles were well defined and where people executed against a plan and could rely on each other to execute against a plan. So bringing together all of the stakeholders, now you can't bring Madison Square Garden, but the leaders of the stakeholders, and make sure the processes are transparent, to force this development of a global action plan, to authorize the existence of a global fund, will signal that in fact this nation is prepared to continue its historic leadership on these global health efforts and actually move the needle to assure that what happened in London doesn't stay in London.
Let me ask just two very specific, concise questions, Mr. Chairman, on this point. So one is the EU has a joint clinical trial initiative in which they've gotten all of the EU countries engaged along with Israel, and we have not joined in yet. And as a nation, I think we should, because this issue of the clinical trials, which you mentioned in your testimony as I was coming in, I think is very, very important. We have opportunities inside of the work that you have talked about in terms of the pharmaceutical community. I've suggested that, not only do we have Alzheimer's, we got 500 plus other diseases and disorders that we haven't come up with effective treatments for. I'm trying to understate this. And I think we should be much more welcoming in terms of trying to get the pharmaceutical industry more full-throatedly involved in this, and even to the degree that we might have to adjust exclusivity issues, patent issues, in ways that could provide more of a runway for them in terms of the fiduciary burdens that they have, or find ways for them to partner, like what the Alzheimer's Association you're doing, for them to do research separate and aside and outside of their fiduciary burdens, so that we can move forward. So if you could react to just to those two things,
Yeah.
then I'll be done.
The Innovative Medicines Institute of Europe has issued a call for proposals, to which the response time is roughly April, to come up with consortia that will develop a Europe-wide clinical trial network system. They've invited the Global CEO Initiative, the industry coalition that I convene, to come up with a North American side to that. And whether that's a side or whether we develop a global platform and we work with them, there is a enormous momentum on both sides of the Atlantic and in Japan, but right now it's focused on both sides of the Atlantic to do something with clinical trial efforts in Alzheimer's, to develop linked patient registries so that we know the characterization that's been made of patients around the world, that they get into longitudinal trials that are well characterized and studied, and that in fact we populate or pre-populate potentially global clinical trial platforms. So that project effort is underway. There's no question it's going to be requiring some government assistance, but hopefully it will also involve some private funding, since the value creation is good for industry as well as for governments. Your second point, yeah, sure.
Well, certainly this issue of improving participation in clinical studies is absolutely essential. We know that already the 3 big prevention studies that are underway, just getting underway in the United States, are going to cause the need for many, many more people than we previously had participate. It's important to note here, if you don't realize already, that one of the things that's happened as a consensus in the science community on this particular condition is that there's a belief that intervening earlier in the disease is absolutely essential. So that's going to mean actually a prevention approach to the disease. The prevention approach means that many of the people who would need to be accrued into clinical studies will not have symptoms, will not have the disease actively in terms of ability to see it other than potentially on a biomarker scan.
What we think of as early onset is pretty far along.
That's
So
exactly
we need
right.
to stop. We need to step in. But my second question was on this question about patent lengthening the period of exclusiveness for treatments and solutions as a way of maybe taking a carrot approach to a more robust effort among the pharmaceutical industry, because right now we're nowhere. We need to get somewhere, and I'm convinced that the academic side of this is very important, but I also think that the pharmaceutical industry is going to be as essential as they were in the example you point out with HIV.
Both, you're absolutely right, Congressman. Both are absolutely essential. Part of the problem, though, has been the underfunding on the front end of the pipeline. This is critical to recognize, because the pharmaceutical companies, if we had sitting here next to us one of the leaders of one of those companies, I've sat on panels with them previously, they would also tell you that they need the fueling of the pipeline. In all diseases, the basic research is not done by the companies, because Wall Street will beat up their stock price. They won't be able to make the investments in the parts of the pipeline, the later stages of development that they need to make. So it's absolutely critical that we tie these things together, not only the kinds of considerations you're raising this particular question on, but also that investment in the front end of the pipeline to make all of this work together.
You'll see in the G8 commitments, there is an explicit commitment: take stock of our current national incentive structure for research, working in partnership with the OECD. So there's an invitation to you, Congressman Fattah, to respond to the G8 by taking stock of our current national incentive structure. I encourage you to do so.
Oh, it's a privilege. And as Chuck has said, we have worked together on so many other issues, including Safe Love initiatives in Africa. So thank you for your work on Alzheimer's. We do have another vote, and it's a big vote, so we're going to have to leave momentarily. But I just want to assure you, Mr. Rayburn, that I'd love to follow up with you on your idea of this global fund. I think it's we just had Mark Dybel testify, and Mark, as you know, was President Bush's drug czar, then became the coordinator, HIV/AIDS czar, and he's now the executive director of the Global Fund for HIV/AIDS, tuberculosis, and malaria. And he used the word very similar to what you've used, the tipping point, Mr. Johns. You mentioned potentially transformational. We are at a tipping point, and we could lose the momentum from the G8 summit if implementation is lackluster and not optimum. So we will do a series of hearings. I think a piece of legislation that tries to galvanize not just Congress but other nations. I think your idea of the working group. I will be leading the delegation to the OSCE Parliamentary Assembly in July. And I'd like to reach out to my fellow parliamentarians. There are 57 countries that make up the OSCE Parliamentary Assembly. They usually send 5, 6 members of their parliament, depending on the country. In terms of Russia, it's usually the one of the top Duma members. Often it's the speaker. So this would be an ideal time to form, do the advanced work, but do, as you suggested, a working group within that venue of the OSCE EPA on Alzheimer's, especially using the G8 action plan as a mobilizing influence. So we all go back to our respective Congresses and parliaments to fight for additional funding and to, make sure that our executive branches as well as our legislative branches are doing all that we ought to be doing to mitigate and hopefully end this horrible disease. We do have this vote, so I'll just ask. I have a lot of questions, but maybe just if there's anything you'd like to leave with us. Your testimonies, again, are very, very extensive, again, filled with information that this subcommittee and members on both sides of the aisle, I know, will go through again and again to pull out and to see what we can do to be of greater value in this all-important fight.
I'm going to just make one quite different point. One of the scarcest commodities in the field, as diverse and eclectic as this, is leadership. And your leadership on this. I know you know the problem. And thus, when we see leadership on Cameron's part, or on Obama's part, or on your part, we need to celebrate it and say, let's go. Because we don't need 500 leaders. But we need a sufficiently motivated, limited number of leaders well-positioned to do what they can do, and then to have that leadership group drive action. And action is the hardest thing to get when you get some diversity like we've got here, with governments globally, industry globally, care problems, not just research problems, globally. This is going to be a problem, a challenge of leadership. So that's the one last point I'd make.
And certainly what I observed in talking to many of the members of Parliament from the UK who were there, and the ministers who are part of the Parliament, of course, in that system, there was an embrace of this particular issue. From Cameron on down through that group, it was pretty clear that they have embraced this issue, recognizing the human impact, the economic impact of the disease if, in fact, action isn't taken on a timely enough basis. They made a commitment to double their investment in research. They are looking at the kinds of things that will speed drug discovery. They're looking at the kinds of things that will move clinical trial participation. So that kind of leadership that you have already shown and that make up the presence of the National Alzheimer's Project Act, to it taking out those things to the next levels, the next steps will be absolutely critical, and the U.S. leadership, again, in particular, will be essential.
Let me just ask you very briefly, you obviously yourselves are doing, I don't know how you can do any more than you're doing, on behalf of Alzheimer's patients, research, and for respite care for those who care, as you mentioned, Mr. Rayburn, about the women who are often the caregivers, how difficult it is for them. And so it becomes an empowerment issue. But it seems to me that one of the tipping points for additional resources was when, on HIV/AIDS, was when the Gates Foundation and others joined in and saw that their money had such a multiplier effect that, are you sensing that Gates and others may be realizing that this is a place where dollars spent now will multiply manyfold for our older Americans and those, of course, who have early onset?
So not particularly from the foundation that you've mentioned because of the way they've defined their particular mission.
But mandates can change.
Certainly, but we are certainly seeing the Alzheimer's Association has been spending a lot of time and effort in the last several years to raise the discussion in the American populace. We know that what happened in cancer, for example, as well as in AIDS, that when it was not discussed, more so in cancer where it was taboo topic to discuss. There was a study in 1961 that asked doctors if they told their patients they had the disease when they made a diagnosis. 90+% of them didn't tell them. It's unimaginable today, but it illustrates the condition at the time of what was a taboo subject to discuss. Too much of that is still present for Alzheimer's, but we've made huge gains in changing that national discussion. We need to change that discussion worldwide too, but we need to make the advances that will continue to have people embrace dealing with this disease. Even the business community hasn't so much wanted to deal with the disease. You don't associate your product with something that people shouldn't discuss. That's the way they've seen it, regrettably, previously. We are seeing cracks in that from the efforts we've made to change that discussion. So I think that parallels the kind of question you pose.
I would say where I'm seeing the appetite is on the part of social impact investing movement. This is a movement that started in the UK, but is beginning to spread globally. And what it is that the $10 trillion of high net worth individual asset management, they do polling of their client base, and these are everywhere from investable assets of $1 million on up. They ask them, would you like your investments to reflect your values? And the answer is yes. But guess what? We have very good systems for measuring financial return on investment. We have lousy systems for measuring social return on investment. And if what we can do is begin to develop a clear plan that demonstrates if you invest $1 billion, Mr. Foundation 1 or 2 or 3, you will get this movement on this unmet need of almost unimaginable proportions. And so what we need to do is get that clarity of plan and demonstrate how the investment of funds will actually have an impact on something that's going to be the scourge of this world if we don't get acting. And that is where I sense there is the possibility here. But what this funding now from these very high net worth investors want is something that says, I want to know when I invest, I will get a social return as well as a financial return.
If I can say, well, I know I have to go, Mr. Chairman. One last thing I would say is that in the question about what can you do, seeing to it that the administrations, this one, the next one, implement the National Alzheimer's Project Act as you wrote it, passed it, and put it into place is absolutely critical oversight on your part to be able to achieve what can be done. Laying out the kind of plan that George just mentioned, which is laid out in that plan, the National Alzheimer's Project Act plan, the plan for the country, the strategic plan for Alzheimer's, is a pathway to changing this in the United States and for providing the nature of the leadership we've discussed for the world. That is one thing I would ask all of you to do. It will make a huge difference.
Thank you. And I do appreciate your leadership.
I'm done.
Thank you, Mr. Weber.
Thank you.
This may sound like a minor point, but to get it on the record, I did notice that the signers of the G-8 were basically ministers of health or secretary of health, except for us. And Don Molds, I'm sure, is a very good man. And but did anyone take away that a acting assistant secretary for planning and evaluation wasn't as
Start with the proposition that Don Moultz is a good man.
I
That
do
that the assistant secretary's position is now acting. He was acting at the time, but also that Secretary Sebelius felt that she had some urgent business to attend to in this country because she was planning to come. So it did not reflect any
They
lack of
understand that
commitment
over
on the
there?
part. Yes, they did.
I did not perceive among the ministers that there was any ill perception, and I too give credit to Mr. Molds for representing us well.
I just wanted to get that on the record and make it clear. I thank you again, and I look forward to working with you on legislation. And we'll see you soon.
Thank you, sir.
Always, Mr. Hammond.
Good job.